Thank you, Respected Chairperson. We have heard about Degludec and Aspart, so my job is to find how we can mix them together, and that's something which is called a co-formulation. And there's slight difference between a premix insulin, and that's something that I would like to focus on. These are the 4 points I'll be covering. The challenges that we face with insulin intensification, followed by the science of co-formulation, and what's the evidence that we have with IDegAsp, which is combining Degludec with Aspart, and some finer points, which are some issues being raised repeatedly on the Degludec part of this story. So I'll be going into it at the end. Now, Dr. Mohan's data. And we are not doing good, definitely not. If you look at the HbA1c, the average HbA1c in the country is around 9 percentage points, which is around 2 percentage points more than the target that we're supposed to achieve, which is less than 7. It's not that it's good in other parts of the world, it's equally bad, except maybe in Germany, where I heard that they have a punishment system if patients or the doctors do not write insulin. So that's the only where the HbA1c is very close to 7. But this is where we stand, and that's because of the difficulty in initiating or intensifying insulin. There's a lot of inertia. Yes, oral drugs, I think this is going to be a very difficult area now with SGLT2, gliptins. What constitutes oral drug failure is going to be, I think, a new CME topic. How many drugs? 4, 5, 6? Before which we consider insulinization. So the inertia might actually increase with time. And it's very easy to start with the basal insulin, which we do very often. And then we try to achieve our targets like fasting glucose under 130 milligrams per deciliter, but the A1C still starts going up. Then we intensify with 1, 2, or 3 prandial insulin as required. So how do we initiate and intensify? So on the left, these are the ways in which we can initiate a basal insulin with OADs, a premix insulin once or twice daily, or again in Germany it's the prandial insulin, which is the initiating insulin. And then we intensify from basal to basal plus, which is 1, 2, or 3 prandial shots. We can also make a switch to premix twice or thrice daily, and then the gold standard, which is basal bolus therapy. We also have premixed from once to twice, or from twice to thrice daily, and always we have the basal bolus to fall back upon. Prandial insulin can also be up-titrated by adding a basal insulin. So you see, it's quite complex. And with this backdrop, suppose we have a patient like this. He's a corporate executive, has a very heavy breakfast, and is on on a sensitizer and a basal insulin. Fasting is pretty well. But when we see the HbA1c is high, and he does a postprandial glucose after breakfast, lunch, and dinner, and everything is high. So it seems this is an ideal candidate for a basal bolus therapy. But if we just ask ourselves the question, making a transition from basal to basal bolus, I think it will be a very big challenge. So can we make things simpler? And if you look at this data, if we add equal amount of carbohydrate at breakfast, lunch, or dinner, and we look at the postprandial spikes, the largest spike is after breakfast. And that's because of the counterregulatory hormones, which are high in the early hours of the morning. Along with the postprandial spikes from the breakfast, we have a large peak. So can we make it simple by adding a single shot of insulin along with the basal insulin? And we have the stepwise study in which patients were put on a basal bolus therapy, or we intensified with 1 shot, if required 2, and if then required, we go to 3 shots. And how do we then target the main meal? So there were 2 steps. So either we target it with the largest meal of the day. We ask the patient, which is your largest meal? Breakfast. So we cover breakfast, lunch, we cover lunch. Or we measure 3 postprandial glucose and target the one which is the largest. But both worked equally well. So whether we measure, or even if my patient doesn't have a glucometer, if I ask and I start insulin, we have absolute equivalent HbA1c lowering at the end of 36 weeks. What was interesting, however, in the study was the greatest reduction was achieved with the first shot of prandial insulin. We are coming very close to the HbA1c of 7 when we add the first shot of prandial insulin, and maybe the second. And if you look at the data, only 40% of the patient actually required the full-fledged basal bolus therapy when we just went from basal to 1 plus to 2 plus. And we can manage near about 20% of patients with a single shot of basal insulin. So we can make things quite simple. And if we just start covering 1 meal at a time, instead of straight away switching to a basal bolus therapy, we can find that there are fewer hypoglycemic episodes. So we can cut down on hypoglycemia, lesser shots, lesser monitoring, lesser cost associated with it. Now, hypoglycemia is bad. We just heard a lot of data from hypoglycemia. It's not only from the cardiovascular perspective. We can correct hypoglycemia with glucose immediately, but the patients actually have a very bad feeling for the rest of the day. If sometimes you ask them, they'll tell you about throbbingness, and they have a heaviness of the head, ill feeling for the rest of the day, until unless it's corrected from the very next day. Not only that, most of the hypoglycemia data have been on surrogate markers. Did you have prospective data? Just like now, for every drug, we need a CVD trial, which shows that, yes, CVD increases mortality. So we tried to look at it, and we thought we need a prospective data. And today we have that. We have the Edinburgh type 2 diabetic study. So patients who had severe hypoglycemia had single episode compared to those who didn't have any episode of hypoglycemia. When they're followed up for 4 years, we find there is statistically significant increase in macrovascular disease, driven by 2 parameters. One, which is coronary artery disease, and myocardial infarction. So this, I think, proves the point. It is bad, and definitely hypoglycemia should be avoided. So, is it possible to intensify or initiate insulin with lesser pricks, with lesser dose, and lesser hypoglycemic episodes? Because that's what we love, that's what our patients love. So with this backdrop, let's go into the co-formulation story. Now, the problems with the first generation analogs, Glargine and Detemir. One, Glargine with the acidic pH could not be combined in the same vial, and Detemir, because of its dissociation properties, couldn't be combined with the prandial insulin. This was overcome with Degludec because it can be combined. It doesn't have the pH problem, it doesn't have the dissociation problem. And so with this backdrop, if you look at this co-formulation with IDEC and ASP, which is called IDegAsp, we find that the dissociation pattern, which is the slow dissociation pattern of Degludec, is maintained, and the rapid dissociation pattern of aspart is also maintained. If you look at the pharmacokinetics and the pharmacodynamics data, this is the interesting part. Aspart is same. If you have a premixed insulin, 3070, aspart is same with the co-formulation, which is IDegAsp. The difference is the Degludec part. Postprandial glucose comes down, but you have a better control of intraprandial glucose because Degludec is acting, its half-life is 25 hours. If I use a protaminated aspart, we find the effect dying down, and there's a gap, after which I inject once again. This is the area where the glucose starts going up. So this is the difference between a premixed insulin and a co-formulation. Now, we did our first data from India, which we published, and we could demonstrate when we make a switch from the first generation analogs to the Degludec, we can achieve the same ends with lesser amount of insulin, with lesser hypoglycemia. And this is exactly because we required lesser prandial insulin because of a prolonged effect, apart from its impact on fasting hyperglycemia. So what is the evidence that we have? Like with Degludec, we had the BEGIN trials. With IDegAsp, we have the BOOST trials. So I'll first show you combined data, which is BOOST Intensify Premix 1 and Intensify All. These were IDegAsp given twice daily. Now the patients were on metformin, which is insulin sensitizers, pioglitazone, and DPP in both the arms. One arm was put on IDegAsp twice daily, another on Bias 30 twice daily. The Japanese data just had metformin, and then the IDegAsp was compared against Bias 30. What we find is that the HbA1c at the end of 26 weeks was absolutely same in both the arms in both the studies, but the Degludec part made the difference. As we saw from BEGIN trials, there was greater reduction in fasting plasma glucose with IDegAsp compared to Bias 30. Not only that, a very interesting data, if the fasting comes down, I start my day very well. If I use aspart here, the post-breakfast 90 minutes glucose is significantly lesser in IDegAsp compared to Bias 30. So if I have if I inject it before breakfast, and if I inject IDegAsp before breakfast, I'm not only going to have a better fasting glucose, I'll also have a better postprandial post-breakfast glucose. So that was significant. The difference was definitely significant between the two arms. So what is the interpretation of the study? Do we interpret that there was similar glycemic control with Degludec versus Glargine when we see the basal part of this story? Because ASP is absolutely same in both the arms. This is not the true interpretation. The true interpretation is all the trials were tricked to target. You have to achieve the same HbA1c. That's the regulation. Now, after achieving the same HbA1c, what are the additional advantages that we have on hypoglycemia, on weight, on insulin requirement, and on fasting plasma glucose? So this is the true interpretation. Now, if we look at the hypoglycemia part of the story from Efficacy, we find there was a significant lesser nocturnal as well as overall hypoglycemia, confirmed hypoglycemia in the IDegAsp arm compared to BIAS 30. This is not exactly replicated in the Intensify All. Yes, there was a greater nocturnal hypoglycemia reduction, though it did not achieve statistical significance. When we pool both the data and we look at the maintenance phase, which is important because here we are not changing the dose anymore. Here the problem is the dose is being changed, so it's very difficult to compare. In the maintenance phase, which is 16 weeks, if you look at the pooled data on hypoglycemia, there is lesser overall severe confirmed and confirmed nocturnal hypoglycemia in the IDegAsp arm compared to BIAS 30. Now these endpoints of equivalent A1C lowering, greater fasting plasma glucose lowering, lower requirement of insulin was achieved with lesser dose of insulin, which was also statistically significant. It required lesser dose of IDegAsp to achieve the same ends compared to BIAS 30. So to summarize, the twice daily IDegAsp usage, it is non-inferior as far as HbA1c, because that's the recommendation. You have to make it non-inferior, but at the cost of greater fasting glucose lowering and greater lowering of nocturnal and overall confirmed hypoglycemia in one study, not the other. Now, if you look at a very interesting point, which is the basal bolus, the patient that we talked about. If we compare a twice-daily IDegAsp versus a full-fledged basal bolus therapy, which is multiple prandial injections, can I achieve the equivalent control like a basal bolus therapy? If you can, with lesser shots, with lesser monitoring, I think it's very easy to intensify insulin. So this was a study which was done, IDegAsp given twice daily with insulin sensitizers, compared to insulin Degludec as a basal insulin given separately, and we added aspart 2, 3, 1, 2, 3, so we have a full-fledged basal bolus therapy. Again, we find there's equivalent A1C lowering in both the arms, equal fasting plasma glucose lowering, and we find slightly lower hypoglycemia, but that did not again achieve statistical significance. What was interesting to note that the same endpoints were achieved with lesser dose of insulin in the IDegAsp arm, which was statistically significant. So lesser shot, but same effect as a basal bolus therapy. And since we required lesser insulin, there was significant lesser weight gain, which was seen in the IDegAsp arm compared to the basal bolus therapy. So here's my patient. I'll just show you. This is a diabetic patient. This is an elderly gentleman, quite disturbed because he was on a basal insulin, just 16 units with metformin glimepiride. And he comes, this is the scanned copy of my prescription, comes with HbA1c of 12.4. And he says, this is not acceptable for me. It has been creeping up. And you see the fasting glucose for his age, I think 135 is not bad, but something was going wrong. And he came with the CGMS data, so things were made very simple for us. And if you look here, except for a small part where the basal insulin was acting, throughout the day, the sugars were actually way off target. So this is an ideal candidate for a basal bolus therapy. Now, he was put on the IDegAsp, very small, 16 in the morning and 10 in the evening, with an insulin sensitizer and a gliptin. And if you look here, from December to April, he has come without hypoglycemia. The A1C has come down to 6.4. Maybe this is too much. Maybe we need to relax the dosage, bring it down. But this has acted like a basal bolus therapy. And that is exactly what the data told us previously. Now, to end, we have the basal plus strategy. Whenever we use a basal and add the single dose of prandial, maybe before breakfast or lunch, we have to have 2 shots. What about doing it with 1 shot? So here's the data in which IDegAsp OD was used with OAD and Glargine was used with OAD. And at the end of the trial, we find larger number of patients achieved their HbA1c of less than 7 without hypoglycemia in the single shot IDegAsp arm compared to the only basal arm. So if we look at, again, the interpretation of this data, similar glycemic control for IDegAsp versus Glargine and no change in hypoglycemia between treatment arms, is this the correct interpretation? Or we have superior HbA1c reduction despite treatment to target design versus Glargine, better glycemic profile, both fasting and postprandial glucose control with lesser hypoglycemia? Well, I think the answer is obvious if you just consider the previous trial. Now, I'll just end with 2 final points. A lot of questions are being raised with the hypoglycemia issues. Different targets, different types of the day, different cutoff values. How can you make a comparison between different basal insulin? Look at all the trials. If you look at DCCT, the definition of hypoglycemia was less than 50. accord less than 50, origin less than 54, severe hypoglycemia less than 36, and begin and boost less than 56. There is absolute inconsistency among studies when it comes to defining hypoglycemia. Nevertheless, if it is required, it is required. It is required to show that less than 70, if you define that as hypoglycemia, then this basal insulin is superior to the other as far as the nocturnal hypoglycemia is concerned. So this study was done. And what did the study show? If you use different timings or different cutoff value, ADA, which is 70, or Novo Nordisk, who use 56, in type 2 diabetic patients, you still maintain the superiority. So you change the targets, you change the goalposts, but you still get the same results. It is seen not only in insulin-naive patients, but even those on basal bolus therapy. You still find changing the timing, changing the glucose hypoglycemia threshold to 70, you still have the benefits. So I think that should settle the hypoglycemia debate. We did our own data, which is pre-publication data on file, head-to-head comparison between Glargine and Glargine and Degludec, and we found significant reduction in hypoglycemia in a real-life setting. So these are not the typical controlled environment. This is the open environment, retrospective data. We again find replication of the data that we found from the clinical trials. Now, if you look at, again, interpretation of this hypoglycemia part of the story, is there a similar risk of hypoglycemia from the second and the first generation analogs? When definition for hypoglycemia was changed, are the benefits lost? Is this the correct interpretation? No. We still find that the advantages were maintained even after changing the goalpost. It is still maintained. Now, see the risk, the last part. FDA has not given approval, so it's not a good drug. It causes some problem in the heart. Is that the interpretation of this data? Now, if you look at this problem, when I think I listened to Steve Nissen himself saying that I brought this FDA MACE data only for oral drugs. I was disappointed why it was extrapolated to insulin, but it is there. This is what the FDA wants. The upper limit of confidence interval is less than 1.3. You get an approval. You don't require to do a CVD study. The upper limit of confidence interval is 1.3 to 1.8. You get an approval, but you need to do a CVD study. The upper limit of confidence interval is more than 1.8. You don't get an approval, and maybe you need to do a CVD study, definitely. Now, in order to get this upper limit of 1.3 or 1.8, you need large number of events, at least 120 CVD events to at least have the 1.8 barrier of the upper limit of confidence interval. If you look at the MACE plus data, which is the original data with Degludec, what do we have? If you see, there were 95 patients who had events. First of all, the number of events were low to even make a calculation. And there were 25 patients who had unstable angina. But in spite of that, if you look at the MACE plus data, we still find that the upper limit of confidence interval was less than 1.8. So the drug, I think, could have been approved anyways. Maybe you should have gone ahead with the cardiovascular data, which they're going ahead with anyways. But then they say, no, we want to get rid of the unstable angina. So it's off. So 95 minus 25, the number goes down to 70. It becomes even more difficult to calculate. And once you do that, you have higher number of events. Is this the way to do a calculation? Look at the origin trial. Look into cardiovascular safety. Look at the accord advance we are talking about, the hazard ratio. It's 2.57 in those who were initially treated with insulin Glargine. The story gets even more complicated. Why didn't you ask them to remove unstable angina? Look at unstable angina, skewing the data completely towards the left. So if we just took off unstable angina from the origin trial, I don't know what the data would have looked like. And if you look here at the next part of the story, I quote from the authors. Subjects without prior CVD events in the origin trials, when allocated to insulin Glargine, had a 17% statistically significant increased risk of the primary co-primaries. So there is no difference in CVD outcomes between the two treatment arms when the whole population was concerned. But with Glargine, there was an increased risk of CV outcomes in those without prior cardiovascular disease. So is Glargine bad? Should we stop writing? This is the type of interpretation we are seeing today. So final answer will come from a CVD trial. It's on, and it's called the DEVOTE trial. Let's wait for it. When it comes, we'll take a call. So what is the true interpretation? FDA did not approve because of lack of efficacy and safety? Not at all. It is that they have their own laws which has to be followed. It's approved in EMA, it's approved by my country. I can use it freely. So my last slide. Where do we position this drug? You can position as twice daily co-formulation, like a basal 2+, because there you have to use 3 shots. I will use it 2 shots. I can use it as an OD, alternate as a basal plus strategy. Instead of 2 shots, I can use it with 1 shot. Or as an alternative to basal bolus therapy, instead of 4 shots, I can use 2 shots. So where I started, I end there. Can we achieve those HbA1c and fasting sugar ends with lesser pricks, with lesser dose, and with lesser hypoglycemic episodes? I think the answer is very obvious. It's yes. Thank you very much.